Joshua Durso-Finley. He is a third-year PhD student at McGill in the probabilistic vision group. His work focuses on estimating treatment effects in order to make treatment decisions tailored to a patient's unique characteristics. The title of his talk is "The Promise of AI for Personalized Medicine Based on Medical Images." Thank you for joining us today, Joshua. The floor is yours.
So this talk is going to be a little less neuro and a little bit more AI. And it's on the promise of AI for personalized medicine based on medical images. So this is some work I've submitted to middle last year and some extensions to McGill this year. So to get started, sort of go to the task we're trying to solve, which is a patient comes in with some symptoms. The doctor takes some information from the patient, maybe takes some few scans and makes a diagnosis, and then goes to make a treatment decision. The problem is there's a variety of treatments available for this patient's illness. So being a good doctor, what they do is they take a look at the clinical trials where these drugs were tested and chooses one with the highest efficacy at the group. So this is the average treatment effect and gives you a good idea of how the drug works in the general population. However, if someone comes along like me and says, well, actually, if you take a look, this patient is a woman. If you take a look at the women in the clinical trials, they actually responded much better to the second drug. So by learning something about the patient, you get a better idea of which drug to treat them with. And this is the conditional average treatment effect. It's sort of a step up where we're taking some patient information and making a better decision. However, this still isn't personalized medicine, and that is sort of the goal that we're trying to achieve. And so personalized medicine is taking patient-specific information, genomic data, MRI data, and choosing now, we'll say, treatment, the last treatment, which is now the most effective for this specific individual. The benefits are fairly obvious for the patient. You get the optimal treatment as quickly as possible. And then there's sort of a secondary effect where you can enrich clinical trials with patients who are likely to respond to a drug. And it gives you a better idea of who will do well on the trial, which speeds up drug development and cost of developing drugs, which again, helps patients out later in the future. Okay, yeah. So this hasn't been done. Most of the people who work on treatment effects work on the sort of conditional average treatment effects and not a lot on the personalized aspect of this, where you're taking the patient's individual characteristics. So I'll talk a little bit about the model that we use to make personalized predictions, and then later on the extension towards uncertainty estimation. And the case study we use is multiple sclerosis. So it's a long-term disease, and it's a complex disease. It's heterogeneous, which makes it an excellent candidate for precision medicine. It presents itself differently in different patients. Different drugs may target different parts of the disease, which allows you to better assign treatments. It's the most common neurological disease affecting young people, and it's prevalent highly in Canada, with the highest rate per capita, and it's characterized by these multifocal lesions visible in MRI. And that's what we focus on for our case study, is the development of these new lesions. So new lesions in the future indicate disease activity. They often correlate with patient disability, but not directly. And there's sort of two types. There's these enlarging lesions, lesions which were there at baseline, and then new lesions which were there 2 years later. And many treatments exist to target these lesions, manage symptoms of the disability, of fine motor skills, of ability to walk, with varying levels of efficacy and different risk profiles for the drug. And it's worth noting that disability often accrues continuously. So finding the drug as quickly as possible can add a lot to the quality of life years that a patient experiences. And lastly, no cure. So finding treatments which can best prolong and improve the patient's life is important as early as possible. So I'll sort of jump right into the model. This is a modification of a causal inference model. It's very common. It's called a TARNet or a T-learner, where it works in sort of 2 stages. In the first stage, we take in some baseline emerged data. This is the part which makes it personalized, as well as the clinical data, demographics, some baseline disability scores, things like that. And it's a multi-headed architecture, which makes a prediction for each treatment efficacy, severity, for the number of new and enlarging T2 lesions, lesions visible on T2, 2 years into the future. So to do this, it's trained on the factual results only. Patient comes in who has placebo. So we trained on a series of clinical trials, randomized clinical trials, which makes our approximations a lot easier for 4 different drugs and placebo comparators. It model learns on the factual assignment. So if a patient got a placebo assignment, the model learns to predict the number of placebo lesions for that patient, and then learns if they had any non-effective drug, it'll learn for the non-effective branch. And then during inference, we get all of these different predictions, and we can make sort of an assessment onto how they'll do. That looks something like this. So this is sort of what would be provided in a support tool, where we have outcomes for each of the drugs. Patient A follows what you would expect from the group level statistics. However, patient B has a bit of a surprise where the no proven efficacy drug, this was a drug that was ineffective at the group level, is actually a reasonable candidate for patient B. In fact, any of these drugs would be reasonable candidates. So that's sort of full stop where you would provide it. However, we'll go through some of the metrics to sort of justify what we're doing. So first, we have a comparator with the clinical features. So these are things which are readily available. You don't need to sit in an MRI. And you get a certain level of average precision when making a prediction for the future lesion count. When we introduce MRI-derived features, so these are the known features, T2 lesion volume, GAD lesion count at baseline. So an expert has to segment these, it takes some time, but it makes sense that these things would correlate with future lesion outcome. Current lesion outcome seems a viable candidate. And then lastly, we have our model, which is just a deep encoder for these MRI and lesion masks, which improves results again. So there's more information to be gained from personalizing the patient prediction. So that the factual sort of out of the way, we move towards the counterfactual. And this is the part that's important for clinical trial enrichment. So the first part is for clinical decision-making, and this is for enrichment. And it's merely just the difference. So we want to take patient A on placebo minus patient A on the highly effective drug, and we'll say a 13 reduction in lesions. And now we want to measure how accurate that is. The problem, there's no patient like patient A on the highly effective treatment. We can make approximations because we've trained sort of this encoder, but we don't really know. So we turn to something called the average difference. And for the average difference, this is just the average outcome on treatment minus the average outcome off treatment. And for a responsive subgroup, what we'd hope is that if you're a responder and you get treatment, you do well. And if you're a responder and you get placebo, you do poorly. So we would expect large differences between the placebo and treatment groups, and that's actually exactly what we see. So sort of focusing on the HE in the top 33%, that's our most responsive subgroup to the highly effective drug. And as we go, and it has an average of minus 15 lesions suppressed. So as we move left to right, from top to bottom, we take less responsive patients. And what we can see is when we take the less responsive patients, we actually have smaller average differences between the treated and untreated groups. And notably, for the highly responsive group for the no proven efficacy drug, NE, the result is significant in reducing lesions where it wasn't at the group level. So we've found patients for it. So this drug does work. It's just that it only works for a certain subgroup of patients. So the next step is there was a problem. There was no patient like patient A on the highly effective treatment. How can we make sure that we're not giving wrong counterfactual predictions? So we do some uncertainty estimation on these counterfactual predictions in order to make a better informed choice. So this merely extends the model to probabilistic estimates of the future lesion outcome and the natural continuation to the individual treatment effects for each treatment. And this lets you take some more probabilistic look at how the patient will develop. On the left is sort of a typical error versus certainty curve, where on the far right of that curve, we have 100% of the patients included. And as we start removing patients based on their predicted uncertainty, we see a reduction in error. So we're indeed more accurate when we make a prediction, and we're certain about it. And then we can start modifying our decision-making to now look at probabilities, probability of favorable outcomes, probability of response. This is sort of a continuous analog of the AD curve from before, where we're finding better responders based on the probability of response, and we get some sensitivity to the actual predictions. So that is that. Thank you for having me.
Great. Do we have any questions for Joshua?
Hey, thanks for the talk. So I'd be curious to hear a bit more about the probabilistic model that you're using for uncertainty. I've done a bit of work in probabilistic deep learning myself, and I know that it can be rather difficult to come up with rigorous uncertainty estimates. So yeah, I'd love to hear more about how you did that in your model. Thanks a lot.
Yep. So we looked at a few ways, actually. The one shown there, we regress the parameters of a Gaussian distribution for the future outcome and then optimize the negative log likelihood of that. But we've also taken a look at dropout-based uncertainty, which shows sort of a similar trend, and ensemble-based uncertainty. But indeed, it's hard to measure the rigorousness of these distributions as we don't have the ground truth future distributions. So all of these are more approximations to the future than really a direct estimate of the uncertainty there.
Cool, thanks.
Great. Thank you for the wonderful talk, Joshua.